George Cooper. I worked in healthcare a long time, and worked in a large Cleveland area hospital. I was director of nursing. I'm an RN by background, and was patient safety officer over the last several years, and then emergency management coordinator in addition to that. So that's how I got my start, writing plans and doing preparedness and so forth, and have come on board with Paratus Solutions doing this. And when Marshall said to me, hey, I've got this this fun little project for you down in Ashland. I like Ashland, I like this area down here. So I thought, oh, this is good. And actually, trying to find an alternate care site plan had been a little bit of a challenge. So, and I'm up to a challenge once in a while. There aren't many models out there for alternate care site plans. So I went out on the internet, I tried to do some literature review and figure out what's out there. And the state of Kansas had a plan that looked pretty nice and a nice model, so that's what this is based on. Alaska had some stuff. There was some work done in Washington, D.C., but there isn't a lot of work that's been done for alternate care sites. And the second thing is there hasn't been a lot of work done for alternate care sites of this type. Most of the alternate care site plans that have been written for surge. So hospital, and Marshall was talking about this earlier, when you evacuate, and Mark was talking about it too, when you evacuate, where do you go? People say, well, let's go to the hospital. Well, those of you who work in hospitals know, there's no beds in hospitals. You can't just pick up all your patients and take them to the hospital and drop them off. And unfortunately, that's kind of the perception everywhere. Cleveland, that's why the work's being done in the Columbus area with Paratus and some of the long-term care facilities there. I'm very familiar with long-term care facilities too, because for the last 6 years, I've served on the board of a very large nonprofit nursing home in Cleveland. My wife, both of our fathers were at the Ohio Veterans Home, spent a long time there. My mother-in-law spent the last 6 years at a nursing home in Cleveland until she passed away recently. And prior to that, 2 years in assisted living, and my wife works in home care and had worked in extended care and so forth. So I'm very familiar with the home care and extended care, long-term care background type situations. So I think that you've got a very unique set of circumstances that you're trying to deal with these residents, and you haven't received a lot of grant money or any kind of funding in the past to help with the work you do, and hospitals have. And so you've kind of been on your own, and so you didn't have the plans in place to deal with that sort of thing. Now let me mention too that as we took the plan that we found from Kansas and we put this plan together, this doesn't deal with evacuating your facility. Hopefully all of you have evacuation plans, and I know the state requires that. They, evacuation training, fire training, that kind of thing in long-term care. So no doubt you have that, but this plan really deals with how this facility here would get set up, and it's a draft. So nothing's carved in stone in this plan. You're the subject matter expert, so if you have input, that's what Vicki was talking about earlier, wanting to be able to look at this plan and review it. And the other thing is you've not had a chance to review the plan. So what I want to do is I just want to list some of the major components of the plan, explain when this alternate care site, this facility would be opened, and then over time, through Vicki and Mark and Ray, start getting input into this. So modification of the plan will follow as needed. The benefit to this process is we need to understand your needs and the community's needs and then ensure that those needs are being met. And I think that's what Vicki talked about earlier too. So there's some planning that has to go into this, and the planning, as Marshall said earlier, should be done long before the disaster occurs. If we don't plan, and I understand, because I remember writing plans and coming in one day and the plans were propping the door open so the door wouldn't close. So we got a plan, then we got to teach people how the plans work and use them for something more than a doorstop. That's what my folks used to use them for, so hopefully yours don't do that as well. Partnering agencies, I'm going to run through these real quick. There are quite a few. Ashland, Homeland Security, Emergency Management, the EMA that is, the Health Department, which is the City County Health Department. I said that in reverse, it's the County City Health Department, Medical Reserve Corps, Samaritan Regional Health System, Emergency medical services, also there's an MOU that has been put together that Vicki and Mark talked about earlier. And so a lot of this is talked about in there, and many of you have already been surveyed. I know someone came out to your facilities and said, okay, who's the different persons in charge? What kind of supplies do you have? Do you have reserve water? Do you have a generator? All that sort of thing. And then also the Red Cross, I believe, will be involved in this whole process going forward. There's some key definitions that I wanted to bring to your attention, and what I've done in the plan, or at least on the slides, is refer to the page number in the plan. So, and you have a copy of the plan in your packet there on page 10. If you look over there, it's actually 10 and 11. We've outlined some of the definitions. I'm sure that you're familiar with most of them. But if you have a question about credentialing, for example, or what is an alternate care site? What's an extended care facility in terms of the plan? What does that refer to? For example, patient or resident. I think we refer to the residents as being patients in the plan. Maybe that's not the right way to, because I know you call them residents. I'm so used to calling them patients in the hospital. So that's a term that could be easily changed in the plan if we decided to do that. What evacuation constitutes, and so forth. So that's out there in the plan itself, and you have a copy of that on page 10 or 11. So if I use a term and you don't understand it, just like MOU, stop me, we'll define it and make sure that we're clear. When would this alternate care site be established? And let me back up and say that alternate care sites, again, for the most part, are surge-type facilities out in the community. When the hospital is already full, what do you do with those patients who would be coming into the hospital? In this case, this is if there's damage to an extended care facility, one or more, and there's a need to shelter residents. That's really what it is. So if your evacuation plans are in order, that would help you then decide who would go to this site. And we'll talk about some of the particulars of this site as we go forward. The scope of this is it's temporary, number one. Number two, each facility would follow their own emergency operation and evacuation plan. And the ambulatory, this alternate, I have to say, I'm so used in the hospital to ambulatory surgery centers, ASC, that I'm going to get confused here eventually before the morning is over. See, I just did it again. The alternate care site would be implemented when the agency exceeds its ability to provide for care. So when you are no longer able to care for your residents, then we would start activating this ACS facility. Here's some of the functions that would be in this alternate care site. And initially, in this plan, it's set up for low acuity only. Vicki was talking about that. That question came up a few minutes ago. It would not be caring for high acuity patients, people with fevers, people who have IVs, you said earlier, if they're on oxygen therapy, ventilators. And there's a good reason for that. What would you venture your guess on that? Why we wouldn't want some of those residents here in this facility?
We can't care for them.
Can't care for them. There's no oxygen here. There's no oxygen tank, and you'd have to bring the oxygen tanks here, exactly. So that's really the reason why right now this facility wouldn't be able to care for them. So those are people in your plan that you would want to look at and say, we need to think about sending them to, another facility where they can be cared for, another extended care facility or a hospital where that person could receive the care they need. Yes, sir.
Just a question on that. A lot of we have quite a few residents that use oxygen.
Yeah.
But I mean, there are oxygen uses through small portables or through, concentrators, that you just plug into the wall.
And that's a good question or comment, and that's something that Vicki and others will want to address.
That's why we need to talk with all of you guys.
Yeah.
To see what are our challenges.
Yeah.
When you're going to evacuate your facility, let's say you have 100 patients and 25 of them are real low acuity. You're just not quite sure what to do with them. They're getting a little twisted. Maybe those are the ones you move out first. They come to a place like this so you can concentrate your efforts on the ones who need to be transferred to other facilities of higher acuity, then we can deal with these patients from here as where they're gonna go. Or maybe it's a temporary, one wing, there was a fire in a wing, we gotta move people. Then do we need to open this? Do you need the stuff that's out there in the hallway? Do you need that to be brought to your place? So a lot of things we
Yeah.
talk about.
And I know in my own personal situation, and I hate bringing up personal type things as we talk about this, but I know from experience that my mother-in-law had an oxygen concentrator, and she wasn't otherwise in any distress, was very low acuity. So maybe that's something that you would consider doing here if they brought their own oxygen concentrator. And we're going to talk about medications, equipment, supplies, those kinds of things. You know, what do you need to provide for the resident when they come here? So low acuity only at this point in time, that's subject to your input and continued writing of the plan. And then offloading of stable patients from your facility, patients, residents who could conceivably come here and be safe, because there's nothing other than food service and housekeeping here at this point in time, and a few supplies. And that's something down the road that may change as well. And then we talked about this already, so I'm not going to go into any more detail about oxygen therapy. It just doesn't exist. There are no reserve tanks. You don't have the, you know, the cylinders and all that you might have in your facilities. On page 11, it talks about coordination of services, and just to kind of bring that to your attention, the agency that would be closing down would request activation. They would be in charge of administration. They manage operations within the scope of their service. So if you needed to evacuate your facility, then you would be the facility who would actually be in charge. We've got a little organizational chart in the presentation here to show that to you. It's also in the plan. But each agency, this is something that's really critical, and I think Mark was, or Vicki, one of you were talking about this earlier. The MOU came out. It's still out there, that not everybody has signed it, for one. And so some of the facilities still have that, need to review it, have their legal person go through that and get it back. And you have copies to give them if they don't, right?
I'll give them to you.
Okay. So if you haven't reviewed that MOU, and that was used, that's something Marshall and I used, is we looked at the plan and put this together. We took that MOU and some of the information that was already gathered last year sometime to put this together. But each agency should really be reviewing the codes, the regulations, licensure, liability, reimbursement issues. Reimbursement may or may not come if you have to evacuate your facility. And part of what Mark said earlier was, if there's a declaration of an emergency, there may be reimbursement, but that reimbursement's very iffy. But you still need to know, how are you going to get reimbursed? If you transfer your residents to this facility, getting reimbursed from their third-party payers. If you send the resident to another facility, another extended care facility, who's going to get reimbursed for that? Who's going to reimburse whom? To figure all that out, who's going to bear the brunt of the cost? So those are things that each facility really would want to look at, and we put some of that in the plan. Maybe that needs to be expanded a bit as we go forward. And I think that's just some critical information there on page 11 that we want you to bear in mind. Planning assumptions, as we looked at this, activation could result from a number of issues, but primarily there'd be limited capacity for patient care, we said. Resources will be scarce, and in fact, this facility is only limited in terms of the availability of resources, fundamentally, right? I mean, how many cots are here, how many personnel could be here, how many supplies, and the mass cash supplies that are out here, I think it's enough for 4 days for, was it 25 residents for 4 days. So it's not a lot of supplies, but it could be 50 people for 2 days.
Yeah. Or 100 per day.
That's true. So
We don't have any beds.
probably the bigger issue is staffing and how staffing is then managed. So those are the things that have to be taken into consideration. The plan can only go so far, and the rest of it is managed by the facility that's requesting the activation of this in cooperation with the EMA and with the hospital and with others that are available. And then some resources may be available through mutual aid. Mark was talking